So those of you who were here last year, this is actually an update. So last year at this time, last fall, we did, Dr. Moeller actually did a presentation on the monoclonal antibody therapies that we are aware of right now to treat Alzheimer's disease. So he very kindly agreed to do an update this year, more of a discussion and analysis of what we know so far. I did practice the names of the monoclonal antibodies. That's all I did all day in my office. He says I don't know how to pronounce them, but those are the three. He'll be pronouncing them lots. But I did want to introduce him, actually. Now, why is this not working? Oh, yes, okay. All right, so I wanted to introduce Dr. Frank Molnar. Now, I told him, as I do every year, you do not need an introduction. Everybody knows you. But for those of you who may not be as familiar, he did want to let you know about his qualifications to present on dementia. Again, it's not needed, but here it is. So back in 1993, Dr. Molnar actually presented at the Medicine Grand Rounds here on the first acetylcholinesterase, which was Tacrin at the time. And since then, he has been investigator or co-investigator on 19 dementia-related grants, more than 160 dementia-related presentations, and has authored or co-authored more than 70 dementia-related publications, which is a lot, let me tell you. And in addition to this, he has contributed to provincial and national dementia strategies and guidelines, including at the Ontario Ministry of Health level, the PHAC Dementia Guidance Initiative, and the Alzheimer's Society of Canada. And for those of you who have been able to see this, just last month in September 2024, he has released a recent publication on this topic that we're going to talk about today with, it seems like, the three Franks, right? Dr. Andrew Frank from Breer Memory Program, who I hope is joining us today online, and Dr. Chris Frank at Queen's in the Canadian Family Physician Journal. And this is the article that I'm talking about. If you haven't had time to read it, it's a very quick read, like a 2-page, but it's a very good summary on what we know so far. Okay, so without further ado, Dr. Molnar, I invite you to the podium. Thank you.
Excellent. So we'll keep questions for the end. We do have academic half day with our residents next week on this topic. So our residents have to think of stuff to talk about. I'm not going to generate it. You have to look at ethical issues, logistic issues, RCT issues. You have to come with the questions and discussions. So you've been warned. So we're going to talk about 3 drugs: aducanumab, which is the Engage and Emerge study, lecanemab, the Clarity trial, and donanemab, Trailblazer trial. I'm going to focus on just the phase 3 trials, not the phase 2 trials that I did last year. And just as we go through this, we're going to be talking about PET scans for amyloid, so you see the amyloid plaques, but also for tau, so you see the neurofibrillary tangles in this little sort of cartoon neuron. I have prescribed cholinesterase inhibitors probably since 1998. But I try to sit in the middle. I've also published systematic reviews indicating the analysis to quantification of almost every cholinesterase inhibitor trial was invalid due to the last observation carried forward an invalid form of analysis. Brought that to FDA, EMA, and the European Union, and Health Canada. So I think the drugs do work in some people, but I do push back on the analysis and think this needs to be rigorous. And I don't accept money from pharma. Even if I go to a dinner, I pay for my own dinner. So I try to stay hands-free. So we're going to review some of what we did last year, but there's been more thought put into some of these trials, only the phase 3 components. We're going to look at the logistics of what we have to build to give these medications. It's going to involve multiple specialties, multiple organizations. We'll look at some of the breakthroughs that are coming as we develop more and more disease-modifying therapies. So we're going to cover a lot of ground. I'd like to thank the people who've provided articles to me. Andrew Frank and Neil Thomas are cognitive neurologists at the Breer Memory Program. They've been fantastic in sort of keeping me abreast and sending me key articles. Dr. Krista Whitney is a geriatrician who trained with us, who's working at the Breer Memory Program, who's also forwarded some key articles. And in our own program at TOH, Alan Wong has sent some of the appropriate use recommendation articles. So I'd like to thank all 4 of them for the articles that we are reviewing. So for those of us who forget, like I do, what are these different phases of trials? So very briefly, preclinical is going to be tissue culture animal models. phase 1 are healthy people. They're just looking at how the drugs work and whether they're toxic. So they're looking at side effects. Only when you get to phase 2 and phase 3 do you have people with the actual disease being trialed. Phase 2 tends to be small. It's just preliminary data. They're still looking at safety. But these are small trials to see, can you do a big phase 3 trial? Phase 3 trials would be the ones that are usually needed for approval. So normally you have to have 2 positive phase 3 trials. You're going to see the landscape has shifted. Now, most countries are giving accelerated approval, 1 phase 3 trial and 1 phase 2 trial, which could be as small as like 45 people. So they've accelerated it, but we'll talk about that. Then it gets approved or doesn't get approved by your national organization. For us, that's Health Canada. Then it goes into phase 4, post-marketing surveillance to see how does it operate in the real world. So we all trained to, think you needed 2 phase 3 trials, but now, as I said, that's not true. You can have a small phase 2B trial, which looks a lot like an RCT. A lot of them look exactly like a small RCT, but they don't have a lot of power. And 1 phase 3, and people are getting, countries are giving accelerated approval. Cummings, who is the world leader in the appropriate use criteria in this field, wrote, after accelerated drug approval, a confirmatory trial, presumably phase 3, is required to assess clinical benefit. And if findings are not confirmatory, the drug can be withdrawn from the market. Doesn't mean it will be, but I can't imagine drug being out there and being used, then being withdrawn. That would create a political firestorm. So we're in an interesting realm where, the standards are changing on us. I'm going to talk about the MCID, minimally clinically important difference. To differentiate statistical significance is just, can you mathematically separate the 2 groups? Is there a tiny little wedge that's probably different? Minimally clinically important difference is something that I grew up with. This was a big concept in my training. So it's the smallest change in treatment outcome that an individual patient would identify as important and which would merit a change in treatment. I've seen some MCIDs go further and also factor in cost. So that would be the time to go for administration. You'll see these infusions, you have to go, some of them every 2 weeks for 18 months. The cost of the drug, the inconvenience, and the risk. So MCIDs can come in various shapes and forms. This is what I was taught. And as we go through this, we're going to ask, is MCID the right measure? It's nice to see that it's gotten into the trials finally, but is it capturing everything we want? One reason to know about these trials is, are we ready to launch these and give these when they're approved? The other is people will ask us about them. And if they're not appropriate, you need to be able to tell them why, right? So even if you're not going to use it, you need to be able to inform people and educate them. So the first one we're going to talk about is aducanumab. And so aducanumab was the first one that came out. There was an eMERGE trial that was high dose and ENGAGE trial low dose. Both trials were stopped before the end due to a futility analysis. I think the eMERGE trial was stopped prematurely. So they stopped enrolling patients because they felt it was going to be a negative trial. But the patients that were already enrolled, they kept following them. I don't know if they kept treating them, but they followed them to the end of that 18-month period, and they found they actually got a positive result. So that's called post-hoc analysis, which has all sorts of methodological problems. And a lot of people think, you cannot rely on a post-hoc analysis where you're just looking backwards in time. So when you looked at eMERGE and when they added the 179 more patients that finished after cessation of enrollment, they found that the CVR sum of boxes, we're going to talk a bit more about that, was different between the group. It was 0.39, and you're going to see that's below the MCID. The MCID is usually 1 to 2 points. So not great. It was a post-hoc analysis. They also saw that the higher the dose of aducanumab you gave, the more amyloid you removed from the brain. So then a firestorm erupted in the FDA. So their advisory committee, 10 of the 11 people on the advisory committee said, do not approve this drug, and 1 abstained. So they said no. The FDA decided to ignore its advisors and approved it. The statisticians even said no. So there was disagreement. There's a lot of political pressure to get a drug out, right? So they're facing tons of political pressure, and they have to balance that with the science. Still, big problems in the FDA. So they got accelerated approval based on 1 trial with post-hoc analysis and based on amyloid being removed from the brain. So, and this just blew up all over the world. There were all sorts of sort of arguments that blew up. So the Canadian Consortium on Neurodegeneration and Aging, the Canadian Geriatric Society, and the C5R, the organization that runs these trials in Canada, got together. They got a big group together, and they also expressed concerns. They said this has not passed the bar of two positive phase 3 trials. Post-hoc analyses are very unreliable. You cannot base approval on a post-hoc analysis. And they said the biomarker removing amyloid is not a valid surrogate measure. And you're going to see that. These drugs remove almost all the amyloid from the brain. It doesn't stop the disease. It doesn't cure the disease. The decline continues, but it's slower. That tells us amyloid is part of the picture, but it's not all of the picture. It doesn't capture all of the disease. So they said, we shouldn't be approving in Canada. They really pushed back. More trials are needed. So this was not approved in Canada in 2021, but a larger trial is ongoing. And you'll see a lot of countries, some countries have approved these drugs. Some have refused to, have declined the drugs, but the trials go on. So even if they're declined, they're going to be applying again and again and again. You're also going to hear that there are 21 drugs in development in phase 3 level. So this field is growing and will explode. The second drug is lecanemab. So just looking at there was a phase 2 trial and a phase 3 trial. So the phase 3 trial was the Clarity trial. The paper was published in 2022. So this is a massive trial, 235 sites in North America, Europe, and Asia at the height of the pandemic. Imagine trying to run that in the pandemic. So what they did, they enrolled, it's the usual double-blind placebo-controlled trial, people 50 to 90 years old, early Alzheimer's disease. So they could have MCI or mild dementia. You can ask, how can you have MCI with Alzheimer's? Well, you had MCI, then they did an amyloid PET or CSF, and they found you had a big amyloid load. So they said the MCI is due to the amyloid. So this highlights one point. These treatments are early on. Once the damage is done, you cannot go back. Once the damage is done, the drugs stop working. So we have to start capturing people at the MCI level, at the pre-disease level almost. This drug is given every 2 weeks. So that's a big, for 18 months, big burden of administration. The other drugs, it's every month. So this one is more frequent. Look at the numbers, 890 in each group. That's about the same as you're going to see for the donanemab trial. That's the proper sample size for this type of trial. They did a great job with randomization. They randomized by whether you're MCI dementia, whether you were on cholinesterase inhibitor memantine, based on your ApoE profile, based on your region, based on CSF and blood markers. So fantastic job with randomization. So they had a lot of measures. I'm going to highlight the most important ones. The clinical dementia rating scale, sum of boxes, is a scale that goes from 0 to 18. 18 is the worst. So in this trial, over 18 months, the CDR sum of boxes decreased 1.21 in lecanemab group and 1.66 in placebo group. So a difference of 0.45. So look at the graphs. It slows down the disease. This is not a cure. My fear is when one of these gets approved in the media, people are going to think this is a cure. Right? And then we'll get all these requests. This is slowing down disease, and it doesn't stop it. So it tells us that some people say that means the amyloid hypothesis is false. No, it tells us amyloid's doing something, but it's not the full treatment. Down the road, we're probably going to see cocktails of treatment, some anti-amyloid with a whole bunch of other things at the same time. So the difference of 0.45, how important is that on a scale of 0 to 18? Well, they have published on MCIDs for CDR sum of boxes, and it's about 1 point for MCI and 1.6 for mild Alzheimer's. So it didn't meet the MCID bar. But once again, it's the MCID, the measure we need. Is that correct? That's group-to-group comparisons. And within the group, you're going to see in the next drug, there may be subgroups we cannot define. And they may be washing out some of the effects. So I was trained to always believe in MCID. I'm starting to question whether that's the only way to look at this data. The ADAS-Cog, Alzheimer's Disease Assessment Scale, cognitive subscales. So that's one of the most common in all dementia trials. This was the 14, 0 to 90. The lecanemab group dropped by 4.14 points, and the placebo by 5.58. So difference of 1.44 out of 18 points. How meaningful is that? Well, we don't have MCID for the ADAS-Cog 14, but we do have it for the 11, and it's 2 points for MCI, 3 points for mild Alzheimer's. So it doesn't cross the MCID bar once again, but there is a positive effect. And so is MCID the only way to look at this? The side effects, I'm going to get into amyloid-related imaging abnormalities, ARIA. You're going to hear ARIA for the next few years till we all know what it means. But the other side effects, which really tell us why if we move forward with this as a division of geriatric medicine, we cannot do this without a partnership with neurology. And we're already reaching out. We have a good relationship with the cognitive neurologist every year, but we would have to have a relationship and a partnership probably with the neurologist, or definitely with the neurologist at TOH if we want to give it. So it can cause seizures, status epilepticus, very rare, but it can happen. Headache, confusion, vision changes, dizziness, nausea, gait difficulty, focal neurological findings. So anytime this happens, if you're the family member, you have to rush the person to the emergency department. You have to get a CAT scan to make sure they don't have a bleed, and then an MRI. So, you know, some of these things are rare, but still you have to have a system that deals with it. There were no deaths in the lecanemab study, but you'll see for the next drug, donanemab, 3 people died and it was attributed to the drug. So these are not benign drugs. You're going to see high cost, $30,000 plus, high risk, maybe high gain. Fever, so you can have a lot of infusion-related reactions. So you have to be able to deal with this on site. Either in your clinic or in the emergency department. So, and if it's very severe, you might have to admit the patient. So fever, flu-like symptoms, chills, aches, shakiness, joint pain, nausea, vomiting, hypotension, hypertension, oxygen desaturation, very common, 1 in 4 people, but you see people who got placebo also got infusion reactions. So you can just get it from IV fluids going on. Serious was quite rare, 1.2%, but you have to be able to deal with it. So you can decrease this with pre-medication, with NSAIDs, with antihistamines and glucocorticoids. Now, we're probably not going to use NSAIDs. You're going to see one of the areas is hemorrhage, bleeding. So if this drug makes you prone to bleeding, you're probably not going to get NSAIDs. So most people are going to think about antihistamines. Antihistamines are anticholinergic in a disease that has a cholinergic deficit. So you're reluctant to do it unless you have to. And glucocorticoids would be another possibility. So most people will probably not pre-medicate except in the patient that's having recurrent infusion reactions. So here we come to amyloid-related imaging abnormalities. ARIA, 2 types of ARIA. ARIA with edema, ARIA E, ARIA with hemorrhage, ARIA H. So this makes sense. You're removing a lot of amyloid from the brain. The images show the brain is shrinking, it's changing its anatomy. That can stretch arteries. You're removing amyloid from the walls of blood vessels. It's not surprising you're going to get some edema and some hemorrhage. But if you're starting to, stretch arteries or change their anatomy, if you're starting to remove amyloid from the wall, you do not want to give anticoagulants, anti-NSAIDs, that sort of drug. So to screen for ARIA, people have to be monitored in the trial with MRIs at week 9, 13, 27, 53, 79, and then 3-month follow-up in this trial. ARIA, so edema can occur spontaneously. It happened to 1.7% of people with placebo, but much higher with the drug, 12.6%. So it can occur spontaneously, tends to be asymptomatic, tends to occur in the first 3 months. So that's an important signal, because in the future, we may be giving these drugs in the community or even at home, but you might want your first 3 months to be in the clinic where you can monitor for these infusion reactions, and you can monitor for cerebral edema and hemorrhage, because it tends to be front end. 2.8% were symptomatic headache, visual disturbance, confusion, straight to CAT scan, then MRI, CAT scan to make sure they're not bleeding, and 0.8% had serious edema. For hemorrhage, and look at these numbers, you're going to see it's higher in the donanemab group. For hemorrhage, ARIA H, you had microhemorrhages, which I'll define macrohemorrhages, and superficial siderosis, so iron deposits from prior bleeds. 17%, but look, it's 9% in placebo, so it's fairly common in people with Alzheimer's dementia. It's almost double. And when they're symptomatic, it's rare, but it presents with dizziness. Macrohemorrhages in 5 of the 898 patients. So what's happened in Canada and US? In the US, this has been approved. It's been approved based on the phase 3 trial Clarity and the one phase 2B trial. When you look at the phase B2 trial had multiple doses, and only in the highest dose with 48 patients were there promising results. So that's pretty weak even at the phase 2 level. It's almost like it's based almost solely on the phase 3. Health Canada is looking at this now. Number 3, donanemab has been approved in the US. I gave away the punchline. So the main study was Trailblazer, altitude. There are multiple Trailblazer studies going on right now. Once again, massive 277 research centers in 8 countries, about the same sample size as lecanemab, 860 and 876. So that's about the ballpark. We're talking 800 to 900 per group. Same type of patients, early symptomatic Alzheimer's, either MCI or mild dementia. But here they did something different, and I think this is really important. They did an amyloid PET and a tau PET. And what they found is the people who had a high tau load did not respond. Low, medium did respond. So high tau may be a mark of too much damage. It's progressed too far. So if we just look at amyloid load, it may not be enough. So you could envision having tau PET, having all sorts of studies layered where you start to shrink and really focus on the population that's safest and most likely to benefit. So I think, to my mind, I didn't see this last year when I looked at it, but knowing that the next study really enriches your sample is really important. Side effects, so the infusions, 74 with donanemab, 4 without, so it can happen spontaneously, but much more. Serious in 3, anaphylactic reactions of 3, but they were mild to moderate and easily manageable, so they didn't have a serious one. 3 deaths related to ARIA. So 2, this is interesting, 2 were ApoE4 heterozygous and 1 was a non-carrier. That's interesting because homozygotes have more edema and hemorrhage. So we expect to see all the homozygotes having severe bleeds and deaths. That's not what they found. I don't know if that will continue. And none were on an anticoagulant or antiplatelet. That's interesting. In lecanemab, you're not supposed to prescribe it to people on anticoagulants or antiplatelets. So that's interesting. We didn't see what we expected there. How much edema? So 1 out of 4, 24% edema, but it can occur spontaneously once again. It occurred in people on placebo, serious in 13 participants. 31%, 1 in 3 had hemorrhage, but then 13% on placebo had hemorrhage. So hemorrhage is common, it's more common on the drug. CDR sum of boxes, the one we talked about before, 0 to 18, 18 being worse. The donanemab group decreased by 1.2 points, and placebo by 1.8, so a difference of 0.67. And even by their definitions, didn't meet the MCID. Their definition was 1 point for MCI and 2 points for mild dementia. So it doesn't meet the MCID. All the curves are the same. It's slowing down decline. It's doing something. Is it doing enough to merit the risks and side effects? And even if it's doing something, when you're looking at group averages, are there patients in there who really benefit and some who don't? Like, is there a dilution? Are there subgroups that really benefit? Well, you can't tell when you look at big group averages. A couple of other scales, and now we're going to change the conversation when we go to purple. The Integrated Alzheimer's Disease Rating Scale. So there's a difference in the two groups of 3.25 points on a 144-point scale. So not a lot to meet the MCID, which is 5 points for MCI and 9 points for mild dementia. So on MCID, it didn't work. But then they changed the conversation, the lens, the narrative. So they started to look at time to event. Can they slow things down? And when they analyzed that way, it looked like on the IA-ERS, it was a 35.1% slowing down of progression over the 18 months. And that's kind of how we're going to talk to patients. We're going to say it slows down your disease by this much. We're not going to say you have this many difference in points on this we've never heard of. So this is getting more to a discussion. So this is changing my lens. I was an MCID trainee, and this is changing the way I'm looking at things. Alzheimer's Disease Cooperative Study, instrumental IDL scales. IDLs found with a 40% less decline in ability to perform IDLs. Once again, this is the way you talk to patients. What's going to happen to your function, not what's your number on the scale. So it's an interesting way to look at this. And then the clinical dementia rating scale, the global score. The global score is stages. So CDR, GS, or G. 0 is MCI versus mild dementia. That's where people get into this trial. 1 is mild dementia, 2 is moderate, 3 is severe. So they found 38.6% lower risk of disease progression. So look at that, 38.6% lower disease progression on CDR, 40% decline in less decline in ability to perform IDLs, and then 35% slowing of decline overall. So we're starting to see an interesting signal. And the authors are starting to pull this out as a different way to look at this. So, they point out on the CDR global score, it delayed progression by 4 months, and by on the CDR sum of boxes by 7 months, and on the CDR-G score 4 months. So let's split the difference, 6 months. It slows things down by 6 months. And 47% of participants CDR sum of boxes at 1 year were stable. So they didn't change their CDR sum of boxes. Only 29% of participants in placebo were stable. So something is happening. Is it enough? And the editorials have picked this up. So Widera has, clearly said there's a slightly less worsening, which is small in absolute values, but slowing down progression by a quarter to half a year, as seen with donanemab, allows someone to remain in MCI or mild stage of dementia for just that much longer. So is that important? It may be to some people. That's actually another way to look at an MCID or to inform patients. So maybe the time to event approach is the way to look at it. Rabinovici pretty much said the same thing, slowing decline by 4.6 months on the IDRS and 7 months on the CDR sum of boxes. So Rabinovici, I didn't know I'd stumble on that one, said presenting the drug's clinical effects in measures that are understandable to patients, that's important, such as transition disease state and time gained. That's important. That's the language we use with patients, will help inform shared decision-making regarding the meaningfulness of benefits for individuals, weighing the risks and costs. So that's important. That's sort of an important way to look at things. So the time to event approach really lends itself to decision aids. And I asked myself, look, if we were talking about cancer and we said this will give you 6 months more, how would we react? We'd probably go, great, we'll take chemotherapy for that. Why don't we do the same for dementia? Part of the reason I think is because we've never had a disease-modifying agent. So you become a bit nihilistic, right? So we have to change the way we're thinking. If we have something that can modify disease progression, maybe we need to think of this differently. So dementia is a fatal disease, right? It progresses, it kills people. We have to start thinking of this more as cancer. And so a whole different frame shift. And there's going to be a lot of reluctance to do this. We've become very nihilistic, understandably, because there haven't been many, really powerful treatments. So time to event may be a way to look at things. Survival analysis curves may be a better way to look at things than our traditional dementia outcome studies. And in the bad old days when Aricept first came out, there was something called responder analysis. I'm going to warn you, FDA hates. So responder analysis, if you could read these curves, essentially has there are 3 bar graphs. So the tallest one is placebo. The middle one is donepezil 5 milligrams, and the black one is donepezil 10 milligrams. And what they're starting to look at is how many people, when you go on one side, are minimally improved, moderately improved, markedly improved, going the other way, minimally worse, moderately worse, markedly worse. This picks up more of a signal of hidden subgroups, but you can't base funding on this or approval, but it might tell us they're hidden subgroups, and we already know they're hidden subgroups from the donanemab trial, right? When we took the people who are amyloid positive and we divided it up by their tau pathology, we got 2 different groups who responded differently. So I kind of like responder analysis as a supplement, but it can never be a primary, but it tells you might be missing stuff. So this field is taking off. It's going to take off like a rocket. The results are getting better and better and better. Even the drugs that are rejected, there are more and more trials coming out, bigger trials, longer trials. Eventually, we're going to start having approval. And my worry is then it's going to be promoted in the media, something that cures Alzheimer's, right? And we're going to get all sorts of calls, all sorts of applications. The regional geriatric program has already had a number of referrals for these drugs that aren't approved in Canada. So this could blow up unless we have some sort of filtering mechanism or some communication. And at some point, we're going to have more drugs. There are 21 disease-modifying agents. So we're going to have multiple drugs, and they might be complementary, like a chemotherapy cocktail. So you might be getting multiple drugs, might be getting cycles of drugs. So you'll have induction, maintenance, surveillance, and other cycles. So this over 20, 30 years, this is going to change dramatically. So who's approved, who's rejected? US and Japan have approved both. The UK rejected lecanemab. Thank you to Dr. Thakin-Spilk. Just yesterday, the UK rejected donanemab. So hot off the presses. Australia rejected and the EU rejected lecanemab, but they're reviewing donanemab, which has better evidence. But remember, even if they're rejected, they're going to keep coming back at them with more and more evidence because there's big money. It's huge money. So are we ready to launch? Absolutely not. We have to start planning the foundation and building the foundation. This will be a 5 to 10 year journey to do this properly. We need better access to amyloid PET, to MRI. Not every radiologist can read these MRIs. They need special training. So the thinking is, these get sent to specific cohort of radiologists who are sort of champions and dedicated. We need better access to ApoE testing, increase infusion clinics. Some of us haven't done an LP in 30 years, so maybe we shouldn't. We need retraining if we're using LP instead of amyloid PET. So you can use either one, CSF or amyloid PET. Who funds this? This is $20,000 to $30,000. Plus, you have to pay for medical infrastructure, the nurses, the doctors, the allied health, the pharmacists, the material, the clinical coordinator, PET, MRI, CSF. So very expensive, and there may be some funding sort of external to organizations, and a lot of partnerships. So people know I'm not shy about this. So geriatric medicine and the RGP combined see thousands of people with dementia every year. Very few people at the Ottawa Hospital know this. So we are leaders in dementia care at TOH, even though it's not acknowledged. Can we do this on our own? Absolutely not. This would definitely need partners from neurology, champions from neurology. We'd have to look at this being a joint sort of effort. As I said, we have a great relationship with Andrew Frank and Neil Thomas, the cognitive neurologist at Bruyere, and they've been super supportive, but we'll need that in-house partnership. We have to have partnerships with neuroradiologists, nuclear medicine. We've made those connections. We've gone to meetings with all of them. With the emergency department, with pharmacy, someone has to prepare the medications, with the day units, so there's a lot of partnerships that have to be built. So who actually can get these medications? So Cummings, as I said, he's the leader in publishing appropriate use recommendations. I've heard him talk, and he's brilliant. So inclusion criteria, you're going to see the organizations that are starting to give these drugs use his criteria. So you can use if you have MCI mild dementia, not moderate dementia, you're too far advanced. Positive amyloid PET or CSF study that indicative of Alzheimer's. If you're outside 50 to 90 year range or have high or low BMI, then that has to be considered. MMSE above 22. They can be on cholinesterase inhibitors or memantine, but they can't be on another monoclonal antibody. You can do standard of care for you can have other illnesses, but you have to be stable. Like you can't be in and out of the hospital because you have to go to these infusion clinics for 18 months. So if you're getting admitted to the hospital in and out, that's not the person who can do this. They have to have a care partner who's willing to take them every 2 to 4 weeks, sit there with them, follow for side effects, bring them to the emergency room. So they can't be half-hearted. They have to be fully committed to this. They have to understand what they're committing to, the benefit, the risks, the cost, the inconvenience. The exclusion criteria, sorry, this is busy. So any acute neurological psychiatric condition that contributes to cognitive impairment, 4 microhemorrhages, 1 macrohemorrhage, which is 10 millimeters, and one area of superficial siderosis, so there's no bleed, vasogenic edema, more than 2 lacunar infarcts, stroke of a major territory, severe microvascular scheme or advanced, amyloid disease, so angiitis, inflammation, so their pathology, MRI of a non-AD, non-Alzheimer's, recent stroke in the last 12 months, recent TIA in the last, or history of seizures, mental health, mental illness, depression that interferes with comprehension, or that could put people at a suicidal risk. So you'll see one of the hospitals does a suicide scale. Any immunological disease, so RA, lupus, Crohn's, and you can't be taking these drugs if you've had systemic treatment with the immunosuppressants. I don't know if steroids counts there. Immunoglobulins, monoclonal antibodies, you can't take these drugs. If you have a bleeding disorder with platelets less than 50, INR greater than 1.5, it's not controlled, you can't take these drugs. For lecanemab, you can't be on anticoagulants. Donanemab, it's different, and you're going to see different centers approach this differently. Some will say, if the person accepts the risk and that unstable condition, you have to be stable enough to be coming to these. So you have to think this person is going to be medically stable for 2 years plus. So when you look at this, you go, who the heck can qualify? And in fact, it is a funnel, right? It is a funnel. This study looked at 237 people who would qualify for these trials. It applied the lecanemab inclusion-exclusion criteria. 237 went to 19. It would be lecanemab inclusion exclusion criteria, 237. So it goes down very quickly to a very enriched population. Even if you treat them, if we have successful treatments, you're delaying progression. So eventually they will come to our service with moderate dementia. So a lot to think about, take years to build. What are other organizations doing? So these two have actually, their electronic publications, the hard copies are coming out, I think, in December. So this is sort of hot off the presses. So the VA Boston Healthcare System and Cedars-Sinai in LA. So I'm going to walk you through the logistics to give you a sense of all the work that needs to be done. This is not going to be launched in 3 months. This is going to be years. But a lot of the work has been done. You can actually borrow from some of these research groups. So this will be in the hard copy of Neurologic Practice in December. So this is the Boston VA Center. So they developed this gives you a sense of partnership. They've developed an interprofessional team of attendings in cognitive behavioral neurology, neuropsychiatry fellows, geriatricians, neuroradiologists, infusion nurses, geriatric clinical pharmacists, second-year geriatric pharmacy residents, physician assistants. So a big group. So there's a lot of partnerships met once a week. So even just trying to get people together in a room is going to be like a nightmare. So you have to have the logistics. They develop streamlined processes and systems for initiation of the drug, for assessment, review, for monitoring, systems to select these people, to find them in their memory clinics and geriatric clinics. They're in there. How do we pull them out? How do we monitor, pull them out? For placing medication orders, for imaging, for monitoring side effects and reactions. So first they had to get approval because their hospital had to pay. So they had to pitch this to the chief of staff. So that's going to be a bit challenging. We're going to have to look at third-party payment, I think. They drafted an infusion protocol, and there are a lot of appendices in this article that you can download. So they've done a lot of work. The infusion protocol went through many rounds that had to be approved by the Pharmacy and Therapeutics Committee. The pharmacy team members then created order sets in like our Epic. So there were order sets built into the EMR. The order sets were not just the drug, but the infusion reaction order sets were automatically built in. They had note templates for the infusion nurses. What did they have to do before, during, and after giving the drug? Templates in the EMR for their meetings and templates for monitoring. So everything was very systematic. So you can borrow this stuff. So it's not a bad idea to let other people start and learn from them and maybe borrow some of their tools, especially if they have a better sort of a priori setup. Forms, there was a checkbox forms for the infusion nurses. So before giving an infusion, they had to be able to verify MRI was done before the 5th, 7th, 14th doses, and it was read and it was approved. So they couldn't go without that. They had templates for their notes. There were patient handouts developed, once again, for the benefits of these drugs, but also for so people genetic results, what's going to happen, right? And you could get quite frightened. Medication handout went through the Education Information Committee, had to be at the 5th grade level. So a lot of work. You can see years of work here. They used Cummings criteria more or less. They added MOCA 16, MMC over 21. Age greater than 65, I think, was a funding issue. So if someone was interested, they were given a handout. That's another appendix. And they were listed in a VA tracking sheet. They were then offered the amyloid PET if they hadn't had one before, an LP for the CSF version. If the amyloid PET or CSF were positive, then they were offered ApoE genetic testing unless it was done before. So when they ordered ApoE, they get a handout explaining it. They met with them, they explained with it a bit of pre-counseling. So you can have a lot of anxiety over some of the thoughts. If they were homozygous for ApoE4, they did not qualify. So up to 20% of people did not qualify. Now that's going to vary from setting to setting. So some people will say no, some systems will say no, some countries will say no, others will say yes, but we have to go through the higher risk level and you have to approve these high risk levels. So you're going to see some variability there. They completed a Columbia suicide rating scale. For sure they weren't at risk for suicide. They had to sign a consent, all placed in the EMR. The eligibility forms had been filled out ahead of time by behavioral neurology, neuropsychiatry fellow or physician assistant. So those were all reviewed carefully to make sure they were complete, no mistakes were made, that they were finalized, and then they were signed off on if they were felt to be appropriate and correct. They put in a consult to pharmacy. And then pharmacy would put in the order set, as well as the infusion side effect orders. So they said, these people have to be accompanied by an adult who can be with them during all the infusions, bring them there, bring them home, monitor them, call them. If there's a problem, bring them into the ED. So not half-hearted family, for example, be fully committed. They had to have someone to reach, like if there's an infusion reaction during the daytime, who do you call? We can do it after hours, weekends, holidays. There had to be someone 24/7 available for them to reach. They had to have the contact number. They can't just be available. They had to be able to figure out who to call. And then they train the residents. What do you do if you see this person in the emergency department? They wouldn't be familiar with that. So they reviewed, if the patient was getting infusions, they reviewed them every week to see how the infusion went. You have to be very labor intensive, very OCD with dangerous drugs like this. Did the infusion go well? Were there complications? The brain MRIs were reviewed for ARIA by the neuroradiologist at 7/14th dose, and then the neuroradiologist and neurologist together in the meeting, so a double check. And the monitoring details were all in that templated note in the EMR. The infusion protocol used diphenhydramine. It was only if one occurred, it wasn't a pre-medication because it's anticholinergic, but if it was recurrent, then they would give a pre-infusion diphenhydramine. So after doing this, they're still working out the bugs, but they realize scaling up is going to be a whole other ballgame. So they're going to need more team members. So they're going to have to scale up to screen and monitor larger numbers of patients. They're going to need physician extenders, nurse practitioners, physician's assistants, maybe expand the roles of the neurology and neuropsychiatry fellows. They have to allocate more staff to this, give them a half day to do this. So they really have to commit HR to this. And in the future, I was surprised by this. I would think this front end involve your emergency department, your stroke team, and critical care. That, to me, that's a front end involvement. So this article has a lot of great appendices. That's the beauty of the article. You can download all of the stuff. How do you inform patients about the drug, the APOE? How do we monitor this? And then in LA Cedars-Sinai, I did something very, very similar. It took them a year to organize this, which is stunning. I think this would take us 5 years. They prioritized, this is the pilot, 10 people, and I like that approach. Just a discrete number, we're doing 10, we're stopping, and then we're reviewing, not just rolling. Given the risk of hemorrhage, the ARIA H, every 2 weeks they reviewed the medications with the patient and family member to make sure they hadn't been prescribed an anticoagulant or anything else that could cause bleeding, including herbal remedies. So they reviewed everything very carefully. They had some financial counseling, and they developed some pretty cool flow charts, which I'm not going to go into, but there's a flow chart for if you show up in the ED, what do you do? Is it ARIA? Is it non-ARIA? So a nice flow chart. That's important when you're in ED, right? Because they're super busy, so they need these flow charts. And for the infusion stuff, do you qualify for the infusion? Did you get it? Did you have side effects? So a nice sort of algorithmic approach that we can follow. So to meet this challenge, we're going to need lots of partnerships. We're starting to develop them. It's going to be a lot of lifting, a lot of planning. That's the blueprint. And at first I had people building a house, but we're not ready to build the house. We're still pouring the foundation. We're even thinking about what we're going to put in the foundation. Still early days. But it's an important foundation because there's 21 more drugs, and there's going to be more and more and more. So that infrastructure you build will support all the different drugs that are coming. So it's not just for the one or two. Stages, external approval. So Health Canada has to approve it. It may decline, and then there'll be more drugs, and these drugs will reapply. Patients are going to ask us about it. So we need to know about it now because they're already asking about these drugs. Then it goes to CADTH. So that's the Canadian Agency for Drug and Technology in Health, now called, as of this year, the Canadian Drug Agency. They look at the cost-benefit analysis. What benefit do you get for the cost? And they provide that analysis to the drug provincial formularies. Then the provincial formularies have to say, are we going to pay? They could say no. So multiple steps. In the interim, people may have to fund this privately or through insurance companies. So each insurance company had different criteria. In the States, it drove them nuts. They all had different forms, and some of them had never heard of the drug. So it was a big thing. Hopefully, some of the same insurance companies carry over. So they've done the work in the US. In Ottawa, we're lucky federal employees are all under one public service insurance. So we're lucky. We need corporate support to build this, multiple partnerships, definitely neurology, neuroradiology, nuclear medicine, ED, critical care, pharmacy. So multiple partnerships. Funding, the clinical coordinator, the one who tracks the patient, is often not funded, and often pharma will fund them external to the organization. So the pharma will fund them, they'll track them in the community and liaise with the hospital group. So there are different models that can be developed, different hybrid models. You have to develop all the processes. We saw you have to dedicate time and effort and run pilots to see, are we doing this right? Are we doing this right? Are we doing this right? So it's not just about the drug, it's also about all the very complex logistics. Final slide, the future game changer. What's going to drop costs and increase access? So genetics said, so big money here, big money. So a lot of companies are getting in the game. So genetic testing is becoming more for E4, it's becoming more accessible. Prevention Genetics is doing it now. It's approved by the Ministry of Health and paid. Dynacare is doing it much cheaper. Ministry of Health has not approved Dynacare yet. So I don't know if that's a quality issue or what, but this probably, so people have to pay out of pocket. The MRI scans, we've reviewed this with neuroradiology, they're very fast scans, 15 minutes with different approaches that can be used. But the MRI radiologists need special training for this. So it might all filter to a specific group. You need to do, if you're doing the LPs, you need CSF analysis. In the past, there was only one lab in Vancouver that did this, did the proper analysis. Now there's one in London, Ontario. Insurance companies that cover the cost, and they said, this is going to explode. There's so many drugs coming. There's so much money to be made here. This would be the biggest breakthrough that everyone's, the holy grail. So blood tests, blood-based biomarkers is a fancy way of saying blood tests that can tell you your amyloid load, right? So you don't have to do the amyloid PET, you don't have to do the LP with the CSF study. The problem is easy blood tests, easy genetic testing, a lot of frightened people who don't understand the results of what they just got. And you could see private companies starting to sell this, and suddenly you've got this big, scary result, and where does that go? So you could see this blowing up. The other big breakthrough, they're already working on this, an injectable form, so we won't need infusion clinics. Now, you probably still want someone on site for the first 3 months when they have the most reactions, and then maybe it can be done in the community. So this is going to take a while, you know, over time, as I said, this will become like oncology. We'll have induction therapy, maintenance therapy, surveillance, cycles of treatment, infusion of multiple agents at the same time. We have to stop thinking of dementia differently than we do cancer. If we can save someone a year of functional life, that's a big deal, right? In cancer, if you told someone in cancer, we're going to give you a year, they go, yeah, we'll pay you $1 million for the drug. But we don't do that in dementia. And that's going to be a battle. That's going to be a political battle because that's not what people want to hear. There's only so much money in the system. So reviewed some of what we did last year, but more thoughts. It struck me, this gives you a sense of the logistics. Our geriatric fellows are listening very carefully because they've got to bring to that academic half day their questions, their debates. I love those discussions. They're very in-depth. This will be a multi-year journey. And I'm glad some neurologists were able to join us. I know Andrew Frank does want to present to the at neurology rounds at some point. Andrew Neil are just fantastic. They really know this field inside out. When they present, I would definitely recommend going. Thank you.
Okay, guys. So we have about 10 minutes for discussion. I think we're gonna go a little bit. A little bit of for those online, I think the easiest might be fastest to actually put your question in the chat. Please do so. And for those, obviously just speak up. I do note that Dr. Chris Frank was on the line. Did you know that, Dr. Muller? So
Excellent.
Very excited to have Dr. Chris Frank from Queens here. So if you wanted to add anything from Queens or Kingston's perspectives, a little bit outside of Ottawa perspective, that would be great. I'm not sure if our neurologists are online. I did not see them list. But yeah, so any questions, guys, please put up your hand or put in the chat. Everybody's saying thank you for a great presentation. And Dr. Dulakia put, actually, you guys can see that too. Yeah, I think I agree with this. Dr. Mulder, this is, I think, do we need to start now? Like, are we going to be prepared? Because Health Canada is reviewing. How soon should we, working groups or?
I think what's probably going to happen is the Gruyere group is going to go first. It's going to be a small number of patients. It's going to be small. And then once it, logistics are built, it'll grow slowly. So small number of patients. They've been giving these infusions in the clinical trials. It's unclear whether Gruyere will allow them to get the actual treatment on the site. That's very different from a logistic point of view, because if they have side effects, then Gruyere Hospital is responsible for that. But they will probably be the first out of the gate, which I think is appropriate. They have younger, more robust patients than we do. We do have patients in our clinic, in our geriatric medicine clinics, who would qualify, who are, 65 to 70, relatively physically healthy. It's not the majority, it is a minority. So you'd have more people in that sort of realm at the Breeder Memory Clinic. And no one site is going to be able to handle all of the volume. I've heard someone say, well, just let them do it. No, you probably need, when this really expands 10 sites across the region, right? This is what it would be like saying, why don't you do dialysis in one hospital? You can't. There are just too many people. So they're probably going to be first out of the gate. We're going to learn from them, we're going to kind of work with them. But we're going to have to build our own infrastructure over a few years. And then once we do, it's really run 1, 2, 3 patients, right? Go really slowly on this and see how it works.
Yeah. I think one thing that we'll need is actually education for both clinicians, because we're the frontline physicians, right? Family physicians, geriatricians, everybody involved in dementia care. We're starting to get these questions. So I think we need education. We need, because once it's out in the media, like you said, once it's on the radio and TV, we're going to start getting questions. So one
question for everybody: what are you going to say when someone shows up and says, "Can I get the monoclonal antibody?" It's like you do have to start thinking about that, right? You have to have the right answer. It's not all about treatment; it's also managing expectations.
Yeah. And I don't know if Geriatric will lead or whoever are working with that, which part of their, their mission that they produce some like education materials, guidelines of like the language and the evidence, what to actually say to the patients. Like you said, like how to actually speak about, we're not going to talk about trials, but what does it mean in real life, right? Like, what are we looking at? 40% reduction instead of us all doing it on our own. Perhaps whatever working groups are working on this could actually publish this stuff, like this kind of thing.
So there have been some meetings that were put together by a pharma company. So there are people from different cities in Ontario and Canada that are looking at this, and some of this cross boundaries. Right? What do you say to patients is not local, but there are some elements that are local. What resources are available? So yeah, I agree. We have to look at this provincially, nationally, because some, and then we can even take some of the attachments to that article and just build on.
Yes.
The other thing we do need, and Andrew Frank and Chris Frank and I sort of talked about this, is we need some filters. So that's what this article is in Canadian Family Physician. So what we don't want is a bunch of blanket referrals. It has exclusion criteria and it has some coming key criteria. So it says, do not send your patients for this if they have A, B, C, D. So we do need some filters. We can't take thousands of patients and try to filter them in our office. That's not going to work. So there should be filters along the way. And it's important for the family physician to say, that's a great question. It's not for you, but you need this other care, like all the other 99% of care. So if this pulls more people into getting the dementia set, great. If they pulls them in early and we can manage their vascular risk factors, their falls, all their other things, great. That will have a big benefit, all the preventative stuff, if people will come earlier for their cognitive assessments. So I agree, we do need to start. Or, there'll be one leading group and study group that'll do it all, and we'll just take it forms.
We may still need a regional approach though, right? Like Ottawa is very, it's so broad and gets so many referrals from outside. I feel like we will have our own challenges. Dr. Frank says, Chris Frank says, we're still in the old age in Kingston, so we need major review of our systems. That's what he said. Chris Goy,
we might get patients from other regions. Like that's going to happen in Toronto. The rural regions are going to feed patients. One way it might get filtered, like Linda Lee has dozens and dozens of primary care memory clinics where the family physicians have become experts in dementia care. And they might be that filter in that first discussion. No, you don't qualify. Yes, you do. We can refer you on. So there might be ways to build this.
Dr. Chris Frank also adds, given the economic and system issues, as well as a higher likelihood of issues with patients with frailty, etc., I'm assuming the focus will be on people quite different than who I currently see in my own clinics or the geriatric medicine clinics, right? Yeah, you said that Greer gets a lot of the earlier, less comorbid or no comorbid. This will be better.
From the ones that she's seen a number of patients who might qualify. Small numbers. We just don't want to be left behind. You want to be cutting edge.
Chris, one of our residents asked, wonderful information about the weather. Do you have insight regarding how disease progression is monitored in clinics once launched? Is it CPR? You know how it's monitored?
Oh, in the clinics, in these two articles that they didn't,
They didn't say how.
they didn't get that far. It's kind of, we set it up and this is how we're giving it. So that's a good question. These might be light cycles.
Yeah. I'm sure the Boston group will have future publications that they learn. Any hands up here, guys? Did I see a flicker of the hand?
Which,
It was stretch. It was like
Zero power.
Dr. Delakia, thanks, Dr. Mulder. With blood-based biomarkers, we attempted to review it at our journal club. The key differentiation is biological AD versus clinical AD. Yeah, while biomarker biological AD trial entry is a robust pathway, the transition to its use to clinical AD is a leap. Any insights would be helpful, but I know it's 5 p.m.
we'll have you come and talk to her.
But that is interesting, right? It's like just because you have the pathology it does not mean you clinically have symptoms, right? And that's where I think at the initial stages, we're gonna have a lot of questions.
So I'm going to say something outrageous because we got to do that once.
Please.
If these drugs don't get immediately approved in Canada, we'll be disappointed, but it does give us more time to get the organized to talk about this, to get the technology going. Once it's like one of them, well.
Yeah.
Yeah, then you need to be able to tell people why you can't get them.
Yeah.
Okay.
Yeah. Okay. 502. Any other last flickers of hands that I can see? No, it's
not a question, but
a comment.
Greg knows this. But I mean, we've been meeting. There's a group from us from here, TOH, and meeting with the Briere group with Neil Thomas and Andrew Frank and other interested doctors there. And we've met with neurology as well. And we have regular meetings to look at new evidence and to see how our planning can start. And at our geriatric medicine clinic, we are talking about a new pathway for the TOH memory program for MCI patients and patients with earlier cognitive symptoms who have no comorbidity. So it's going to look very much like our false clinic, single system thing. And we basically dusted off Dr. Bill Dalziel's previous attempt at MCI clinic. When we look at it and compare it to our, this document that Dr. Mona has published recently and say, how can we make that? I mean, we're planning to launch that fairly soon.
Yeah.
So it's not going to increase our workload, but just to have a separate stream to really, see what's the volume of referral we will get when we look at a population of patients who have, earlier cognitive symptoms, no major comorbidities. And for that, we're already planning that. So
It's starting. It's already on the
Maybe a flicker of question, Frank. For her, do you know anything about the dry blood sample? There's one lab in BC doing the amyloid and tau, and they can just do a drop of blood, dried sample, send back, but there is a risk of false positives.
Whole other set of rounds. That'll be something Andrew Frank or Neil Thomas do. So I can't understand some of the technology. There are some assays that with machinery that no one does. It's one lab. So you can, but Andrew and Neil have been in touch with TOH labs. So there is some possibility they can do some of this CSF and blood-based biomarkers in the future. They do have a platform for some of the tests, but not all.
Thank you. Such a scary, big topic. Thank you so much.